Hi everyone, welcome back. This is part 4 of the video series on anemia, and in the prior videos we finished learning about micro and macrocytic anemia. So in this video we're going to learn about the final class type, which is normocytic anemia. So in this video I'm going to cover two things. Number one, how normocytic anemia is divided into hemolytic and non-hemolytic causes, and then number two, the specific details about the non-hemolytic causes, and then you'll learn about the hemolytic causes in the next video of the series. But for now, if you're ready to learn about this, let's get started. Okay, so in video 1 of the series, we started talking about what anemia is, and we introduced this diagnostic algorithm. So as a quick refresher, anemia is a decrease in the red blood cell mass, and it's diagnosed by a low hemoglobin and hematocrit on a CBC. So this is the key lab value here, a low hemoglobin and hematocrit equals anemia. But once we find this, we're not done, because now we have to figure out what caused the anemia, and there are many different diseases that cause it. So we use a diagnostic algorithm to help us narrow the differential diagnosis, and this algorithm uses the MCV of the red blood cells. So diseases that cause anemia with low MCV are going to be put in this bucket of microcytic anemia. Those with normal MCV are going to be in this bucket of normocytic. And finally, those with high MCV are going to be in this bucket of macrocytic. And in this video, we're going to focus on this category, which is normocytic anemia. So this is when we have anemia and the MCV is between 80 to 100 centiliters, so in the normal range. And the causes of normocytic anemia are either hemolytic or non-hemolytic. So in hemolysis, the problem is excessive breakdown of red blood cells, so overdestruction, whereas in non-hemolytic diseases, the problem is impaired production of red blood cells, so underproduction. And as they love to ask you on exam questions, when you have a normocytic anemia, what is the next best step? And the answer is very clear. It is a reticulocyte level, because it's going to be high in hemolysis and it's going to be low in the non-hemolytic causes. So this will quickly guide you down the next step and help you figure out the cause. So the main takeaway here is when you have a normocytic anemia, the best test is the retic level. High means hemolysis, low means non-hemolysis. So let's learn about these reticulocytes. Red blood cells are made in the bone marrow. This process is called erythropoiesis, which means generation of erythrocytes, which are red blood cells. And the way that it works is that we're going to start off with these red blood cell progenitor cells. And after a bunch of series of divisions and differentiation, we're going to end up with this red blood cell that's finally ready to leave the bone marrow, hit the circulation, and do its job. And this version of the red blood cell that leaves the bone marrow and enters the blood is called our reticulocyte. So reticulocytes are the initial red blood cells that enter the blood from the bone marrow directly, and they're considered immature red blood cells because unlike mature red blood cells, which only contain hemoglobin and nothing else, reticulocytes also still contain a little bit of ribosomes and ribosomal RNA. And after circulating in the blood for 1 to 2 days, they're going to lose this remaining ribosomal stuff. So they're now purely hemoglobin packed, and they're matured into the final red blood cell form, and they're going to circulate for their lifespan, which is about 120 days. Now, what's most important to know about these cells is how we can use them clinically. Because these cells, these reticulocytes, are the red blood cells that are directly secreted into the blood from the bone marrow, their levels inside of blood is a direct measure of how much red blood cell production is going on in the bone marrow, aka erythropoiesis. So when a patient's reticulocyte levels in the blood are high, that means that the bone marrow is pumping out a lot of red blood cells, and so red blood cell generation in the bone marrow is high. On the other hand, when reticulocyte levels in the blood are low, that means that the bone marrow is struggling to make red blood cells, so red blood cell production is impaired. So how does this all tie in with hemolytic versus non-hemolytic causes of normocytic anemia? Well, let's start with hemolytic first. So these are diseases like sickle cell, G6PD, and several other important ones, and I'll cover them all in detail in the next video in this series. But for now, what's important to know is that in hemolysis, hemo refers to red blood cells and lysis refers to their destruction. So the problem in hemolysis is excessive destruction of the red blood cells, and this is how it causes anemia. So the bone marrow is going to get a signal that there's severe anemia, and it's going to say, hey, we have a problem. We need to increase production. So it's going to rev up erythropoiesis and red blood cell generation. And this is going to lead to more reticulocytes being made and pumped out into blood. And this is why reticulocyte levels in hemolytic anemia are going to be high. Now, what about a non-hemolytic anemia? So the main causes in this category clinically and on the board exams are listed here, and these are definitely the top 5 that you should know. We have chronic kidney disease, aplastic anemia, Parvovirus B19, Iron Deficiency, and Anemia of Chronic Disease. And I'll go through each of these in detail later on in this video, but for now, what's important is that in all these diseases, they're all going to cause underproduction of red blood cells. And of course, producing less red blood cells is going to cause anemia. So that's the mechanism here, underproduction of red blood cells. So in this case, the bone marrow can't compensate for the anemia because we have a primary issue with erythropoiesis. Something is hampering the synthesis of our red blood cells. So as a result, less reticulocytes are going to be made and pumped into the blood. And this is why reticulocyte levels in non-hemolytic anemia are going to be low. Okay, so now we know that in normocytic anemia, high retic levels means the problem is hemolysis. So the only question left is, how do you know whether a reticulocyte level is high or low? What gives you this information? So there are actually two values here that can answer this question for you. So the first one is called the reticulocyte count. It's called a count, but it's actually a percentage of reticulocytes over total red blood cells in the blood. So it basically tells us from all the red blood cells that are circulating, what percent of them are reticulocytes, and the normal level without anemia is 0.5 to 1.5%. So in hemolysis, the number should be much higher, and the value you want to keep in mind for hemolysis for a reticulocyte count is anything greater than 3%. Now, there's a little problem with the reticulocyte count, and it's because it's a percentage, so it is falsely elevated in anemia because our denominator is low since we have less total red blood cells in anemia, and also reticulocytes are released earlier from the bone marrow in anemia. So to get a more accurate sense of actual reticulocyte production, we can use this second value, which is the reticulocyte production index. What it does is it corrects for the low hematocrit of the patient, by getting a corrected reticulocyte count, by multiplying it by the patient's hematocrit over a normal hematocrit, and it also corrects for the early release of the reticulocytes using this maturation time factor, and the value that's going to be provided at the end, which is the RPI, or the reticulocyte production index, is considered the gold standard for measuring reticulocyte levels. So an RPI greater than 3 is hemolytic, and RPI less than 2 is non-hemolytic, and if it's in between 2 to 3, then it's going to be in a gray zone, and you'd need to use other clues to figure it out, but it would be very, very unlikely you'd get something like that on a test question. Usually they're very clearly either above 3 or below 2. So to summarize, on a question where you have to interpret whether a patient has high or low reticulocytes, either of these two parameters will be provided for you. If the reticulocyte count is greater than 3%, or if the RPI is greater than 3, then most likely you're dealing with a hemolytic anemia. Okay, so let's recap our normocytic anemia algorithm so far. We have a low hemoglobin and hematocrit, which is anemia. Next step is MCV, and it's normocytic, so 80 to 100. So next step is check retic levels. In hemolysis, retic levels are high. In non-hemolysis, primarily the issue is going to be underproduction, so retic levels are low, and these are the main causes of underproduction that we're going to go through soon. But first, there's just one more and final cause of normocytic anemia that doesn't fit into either category of underproduction or hemolysis, and that is hemorrhage or blood loss. So let's talk about that here. Imagine that someone has a serious hemorrhage from an accident or a GI bleed. Well, this person is going to get anemia from their blood loss, and it's going to be normocytic, but what about the reticulocytes? Are they going to be high or low? Most board exam resources just list this under non-hemolytic and say that the retic count will be low, but that's not entirely correct, and it can cause you to get confused or miss things. The real answer is that it depends on the timing from the blood loss. So as a consequence of the blood loss, the bone marrow is of course going to increase red blood cell production, so you would actually expect high reticulocytes, kind of like we see in hemolysis. But remember that making new cells takes time, so it's not going to be reflected right away. So what you're actually going to see is that in the first 1 to 2 days after the hemorrhage, the reticulocytes are going to remain low because they haven't yet been made and released into the blood. But then after 2 to 3 days after the hemorrhage, now they've been made, released into the blood, so now the reticulocyte levels are actually going to be high. So the bottom line is that in hemorrhage or blood loss, we're also going to get normocytic anemia in the first 1 to 2 days, so the super acute phase, retic levels are low, and then after that, the retic levels are going to be high as the bone marrow is compensating for the blood loss. Okay, so now for the rest of this video, we're going to focus on the underproduction causes of normocytic anemia. And as I said before, there are 5 main causes that I've listed again here. We're going to go through each of them one at a time. So kidneys secrete the hormone erythropoietin, or EPO. This hormone acts on the bone marrow to stimulate erythropoiesis, which is where the erythroid precursor cells are going to differentiate into our red blood cells. And as part of this process, the main thing that these cells need to do is to build a lot of hemoglobin inside of them from iron. And once they're ready and they have enough hemoglobin, they can get released from the bone marrow into blood. Now, in each of our 5 causes that we're going to learn now, one of the steps in this process is disrupted, which is going to lead to decreased production of red blood cells. So I'll keep referring back to this simple sketch as we go through each condition. So let's start with chronic kidney disease. The mechanism here is simple. The problem is severe kidney disease. So when kidney's bad, it can't secrete EPO. If we don't have EPO, we don't have erythropoiesis in the bone marrow, and we're going to have decreased red blood cell production. Most common causes in the US are hypertension and diabetes, but it can also be caused from polycystic kidney disease, glomerulonephritis, or really any other condition that causes significant chronic kidney damage. So the cause doesn't really matter. If we have chronic kidney disease, it can lead to this type of anemia. There's a couple of lab findings that are going to clue you in that this is the diagnosis. First, of course, you have to have abnormal kidney function tests to confirm that this is chronic kidney disease. The main ones here are going to be increased creatinine and a decreased GFR. And then the other lab finding, especially for exam questions, that's a big clue, is that there's going to be a decrease in the serum EPO levels. Remember, the underlying problem here is with the kidneys that it can't secrete EPO, so the levels are going to be low. So it's a very important clue if you see it. That's going to help you distinguish it from all the following ones that we're going to learn about next. Okay, so let's move on to aplastic anemia. Aplasia is the opposite of hyperplasia, so it means the absence of cells. So the mechanism here is a problem with the bone marrow itself that causes a loss or absence of these hematopoietic stem cells. So you're not going to have the precursor red blood cells, therefore you can't do erythropoiesis. And so this is going to lead to a decrease in production of red blood cells due to aplasia or absence of the precursor cells. Now, there are many different causes for aplastic anemia. I'm going to run through the main high-yield ones that you need to know here. The most common cause is idiopathic. That means we don't know the exact trigger in these cases, but we do know that it's usually mediated by the immune system attacking the hematopoietic stem cells in the bone marrow and causing their destruction. Next is viruses. So some viruses can rarely cause aplastic anemia. Main ones that do this are hepatitis, Epstein-Barr virus, which causes mono, CMV, and HIV. Next, there are some medications that you should know. Of course, chemotherapy can cause aplastic anemia because the side effect of many of the chemo drugs target the bone marrow's rapidly dividing cells. And also, there's an antibiotic called chloramphenicol. This one classically can cause aplastic anemia, and in fact, this antibiotic is rarely ever used anymore because of this side effect, but it does show up at USMLE hospital, so you should definitely know it for your exams. Next are toxic exposures. So other toxins such as benzene as well as ionizing radiation can damage the bone marrow and cause aplastic anemia. And relevant to this ionizing radiation, this is a picture of Marie Curie. She was an amazing scientist who studied radioactivity, and she actually became the first woman to win a Nobel Prize and the first person to win the Nobel Prize twice. Unfortunately, she died from aplastic anemia from her long-term exposure to this ionizing radiation as part of her research and work. And then finally, inherited gene mutations in these hematopoietic stem cells can also cause aplastic anemia. The most classic one is this one right here, which is Fanconi anemia, which can also cause both normocytic and macrocytic anemia. It's a DNA repair defect, and I talk about it in more detail in the video that I have on macrocytic anemia, and I'll link that video at the end so you can check it out. But what's very important about aplastic anemia is knowing these 2 important clues to make the diagnosis. So number 1 is the CBC is going to show pancytopenia. So that means not only anemia, but also low white blood cells and platelets. And that's because all of the hematopoietic stem cells are down. So all 3 cell lines are going to be affected. And this is a big clue. The next one is going to be the bone marrow biopsy. So the buzzwords here are hypocellular, meaning that there's much fewer pockets of blood cells because of the aplastic situation, and then fatty or lipid infiltration of the bone marrow. So basically, as you can see in the bone marrow biopsy right here, the normal white blood cell, platelet, and red blood cell precursor cells of the bone marrow are gone, and in their place, there's just a lot of adipocytes or fat cells hanging out in the bone marrow, and this is the key classic finding and the confirmatory diagnostic test for aplastic anemia. Okay, so let's move on to the next cause, which is infection by a virus called Parvovirus B19. This is a DNA virus. In fact, a fun fact for the micro portion of the USMLE is that it is the smallest DNA virus that infects humans, and it's transmitted by the respiratory route most commonly, but it can also be passed down from mom to fetus during pregnancy. And the problem with this virus is that it has a very specific interest in attacking red blood cell precursor cells in the bone marrow, and the reason that it can get into those cells specifically is because because those red blood cell precursors have a specific receptor on their surface called the P antigen, and this parvovirus, which starts with the letter P, by the way, if you're looking for a mnemonic, can use this P antigen to get into the red blood cells, and once inside these precursors, it can cause damage and prevent them from developing in the bone marrow, and so we end up with decreased red blood cell production in the bone marrow, which leads to the underproduction anemia. So now let's see how this is going to present clinically. Most infections are going to be asymptomatic, so they're not going to cause significant anemia, and that's because the infection usually only lasts a few days, and most people have plenty of reserve to outlast the infection time without getting anemia from it. But there are 3 types of clinical conditions that you should know that are associated when it does have symptoms. So number 1 is in children. It can cause what's called erythema infectiosum, or fit disease. And the key findings here are a high fever and a classic red rash on the face that's called a slapped cheek rash because it causes redness of both cheeks. And as I said before, you're not going to expect anemia here unless the child has some underlying red blood cell disorder because the disease is transient and goes away. So besides the rash and the fever, there's not much else with this one. But number 2 is very serious. This is when you get it in utero. So this is a congenital infection of Parvovirus B19 being passed down from the mom. So it's actually one of the torch infections under the category of O for other. And so this is going to cause severe anemia in utero, which can lead to high output heart failure called hydrops fetalis. And unfortunately, this usually becomes very serious and can cause death in utero. And then finally, number 3 is aplastic crisis. So this is when a child or an adult with an underlying red blood cell disorder, so for example, somebody with a hemolytic disease like sickle cell, gets infected with this virus. Now, I said before that in most people, this infection is not going to cause an anemia because they have plenty of reserve, but that's not the case in people who have hemolytic diseases like sickle cell or hereditary spherocytosis or others. These patients depend on their bone marrow to be constantly working overtime and pumping out extra red blood cells to make up for that chronic hemolysis that's always happening. So they are actually very sensitive to anything that slows down the bone marrow even for a little bit. So this is going to cause a severe anemia in these patients due to decreased production of the red blood cells, which is why it's called aplastic. So number 1, they're going to have some underlying red blood cell disorder, especially a hemolytic disease in their past medical history. And then number 2, if you check reticulocytes, they're going to be low. So remember, in hemolytic anemia, you expect high reticulocytes because of the compensation for hemolysis. So when the retics are low, that means that the patient is in an aplastic crisis because their bone marrow is failing to compensate. And the major cause of this crisis is this Parvovirus B19 infection. And then finally, number 3, it can be easy to confuse the terms aplastic crisis, which is this one, with aplastic anemia, which is what we talked about on the prior slide, because they both start with aplastic. But it's very important that you don't confuse them because they're completely different conditions. So the key here to help you tell them apart is the CBC. Remember that in the aplastic anemia one, the problem involved all the bone marrow stem cells. So all 3 cell lines were down and our CBC showed pancytopenia. But in aplastic crisis, Parvovirus mainly likes to get into the red blood cell progenitor cells because of that P antigen. It doesn't so much affect the platelets and white blood cells. So the CBC in aplastic crisis is going to show anemia only. The white blood cells and platelets usually aren't affected. Okay, so now let's wrap up by talking about iron deficiency anemia and anemia of chronic disease. Both of these cause normocytic anemia early, but microcytic anemia as the disease becomes more advanced. So I talk about both of these in much more detail in the video on microcytic anemia, which I'll link at the end as well. But for now, I'll do a quick review of their main points here just to be complete. So in both of these conditions, the problem is that the red blood cell precursors in the bone marrow are lacking the iron they need to make hemoglobin. And if you can't make hemoglobin, you can't make red blood cells. So this lack of iron for the red blood cells is the cause for the underproduction anemia in both cases. The difference is that in iron deficiency anemia, the problem is that the entire body is low or deficient in iron, but in the anemia of chronic disease, this chronic disease is causing high levels of hepcidin, which is trapping the iron in the macrophages. So the body isn't deficient in iron, the iron just can't make it out of the macrophages to get to the bone marrow. So now let's talk about their causes. So iron deficiency is caused by either decrease in intake or absorption of iron or increase in the demand for iron or iron loss through blood loss. One example of this increased demand is again in someone who has hemolytic disease. They're constantly using up extra iron to make more red blood cells to compensate for the hemolysis. So as a consequence, they're at higher risk for becoming iron deficient. So if you see a hemolytic disease patient and the reticulocyte count is low, one of the other causes you need to consider is iron deficiency anemia from increased demand. For anemia of chronic disease, the causes, of course, are going to be chronic diseases, and the main ones are going to be cancer, chronic autoimmune disease, and chronic infection. Now, the key findings here are going to be anemia, of course, with low reticulocytes because this is underproduction, and then you're going to get hypochromia on the blood smear because of the decrease in the hemoglobin synthesis. And as I mentioned earlier, these can cause normocytic anemia early and microcytic anemia later as the disease progresses. And then finally, the way to tell them apart is by using iron studies. So in iron deficiency anemia, the ferritin is low and the TIBC is high. In anemia of chronic disease, you have the opposite. So ferritin is high and TIBC is low. And if you need a good video to help you with iron studies, I'll link that one at the end as well. Okay, we learned a lot in this video, so let's finish up by recapping the main points about the causes of underproduction anemia. So chronic kidney disease affects the kidneys, aplastic anemia and parvovirus affect the bone marrow, and then iron deficiency anemia and anemia of chronic disease affect hemoglobin synthesis because of lack of iron. So in chronic kidney disease, because the problem is the kidney, we have decreased erythropoietin secretion. So our key findings are going to be abnormal kidney function tests, low serum EPO levels. In aplastic anemia and Parvo B19, the problem is in the bone marrow. The difference is that in aplastic anemia, we're going to have problems with all the hematopoietic stem cells. So we get pancytopenia, and the bone marrow biopsy is going to show a hypocellular marrow with fatty infiltration. Whereas in Parvo B19, which causes aplastic crisis, not anemia, this is going to affect just the red blood cell precursors. So we get anemia only, not pancytopenia, and it's going to primarily just affect people with underlying red blood cell disorders like hemolytic diseases. And then finally, in iron deficiency and anemia of chronic disease, the problem is that there's less iron available for the red blood cells. In iron deficiency, the body is deficient in iron, whereas in anemia of chronic disease, the iron is trapped inside the macrophages. And these two can both cause normocytic and microcytic anemia as well. And the way to tell them apart is by using the iron studies parameters that are in this table. Okay, that's it and that's all. If you want to learn more about this topic, you can check out some of the other videos that I've linked here. And if you guys enjoyed this video, don't forget to like or drop a comment and let me know. Also, don't forget to share this with others and subscribe to the channel so that you don't miss out on upcoming content. But for now, thanks for watching and I'll see you next time.